Hi friends, welcome to my blog ECG Basic. Today we will be discussing about the ventricular hypertrophy. Ventricular hypertrophy shows, especially the left ventricular hypertrophy, shows two types of pattern. First is the pressure overload and second is the volume overload. Pressure overload is when the afterload is very high. That is in the conditions of systemic hypertension, pulmonary hypertension, aortic stenosis, hypertrophic cardiomyopathies, and volume overload is seen in the states of aortic regurgitation, mitral regurgitation. Whenever there is a pressure overload, we get tall R wave with slurred ST segment or inverted T waves. This is called strain pattern. Strain pattern means the T wave is like this. It is not like U shape. This type of T wave is called asymmetrical T wave inversion, and this is symmetrical T wave inversion. This asymmetrical T wave inversion can be normal, but this symmetrical T wave inversion, whenever is present, we it can be early sign of ischemia, and we should rule out the cause of ischemia. This asymmetrical T wave inversion is characteristic feature of pressure overload. That is, it shows a strain pattern. So in pressure overload, we get a tall R wave with slurred ST segment and asymmetrical T wave that is shows strain pattern. The tall R wave they are also present in volume overload state, but here that we have upright T wave. There is no T wave inversion, and also we have deep Q wave in V6, and we can have inverted U wave. Deep Q wave I have already mentioned in my previous vlogs that it indicates the cavity potential that is end diastolic ventricular cavity potential. So in LV left ventricular hypertrophy, since there is more mass of the ventricle, that's why it shows tall R wave. When it is due to pressure overload, we get tall R wave, slurred ST segment, inverted T wave, that is asymmetrical T wave, suggestive of strain pattern in lead V6. And if the hypertrophy is due to volume overload, we get tall R wave, upright T wave, deep Q wave, and inverted U wave. LVH shows three types of pattern, right? Left ventricular concentric hypertrophy, eccentric hypertrophy, and concentric remodeling. In concentric left ventricular hypertrophy, there is increased global left wall thickness, normal, but the cavity size is usually normal. This cavity size is normal, though that there is thickness, increased thickness of the ventricular wall, but the cavity size remains normal. In eccentric LVH, there is increased wall thickness, but the cavity size increases. Cavity size increases. Here in the concentric remodeling, there is also increased left wall thickness, but the cavity size may be normal or it is decreased. So, in concentric LPH, the cavity size is normal. In eccentric LPH, the cavity size increases, and in concentric remodeling, the cavity size may be normal or it may be decreased. Whenever there is eccentric LVH, as if I just if this is a sternum and this is the heart, when the cavities this is the hypertrophy of the left ventricle. If the cavity size increases, then the ventricle reaches near the sternum. So whenever the any lead is placed here, it will give more deflection. Since there is increase in size of the cavity, there is increased quantity of the blood In the cavity, blood is also a good conductor of electric current. So, with the hypertrophy and the increased cavity side, we get deep Q wave in V6. So, whenever there is eccentric LVH with increased cavity, because of increased cavity, we get deep Q wave besides changes of the left ventricular hypertrophy. The Q waves are not always present, but whenever they are present in V6 with signs of LVH, we must think of cavity potential. That is, it is because of volume overload. This term was explained by Brody, so we call it as a Brody effect. Here we can see uh, deep Q wave in lead V6, and whenever there is LVH plus deep Q wave, this phenomenon is called Brody's effect, and it is suggestive of cavity potential. That is, LVH is due to volume overload. These are the few criteria for diagnosis of the right ventricular hypertrophy. For right ventricular hypertrophy, you need not remember all these. Just remember few of them, like this first one. Ratio of R and S wave in V1 more than 1. And second one you can remember as uh, S wave in V5 and V6 more than equal to 7 mm. Or we can also remember QR in V1 and R oblique S wave in V5, V6 less than equal to 1. If we see the heart like this is a septum, this is the right ventricle. Due to the hypertrophy of the right ventricle, whenever this is the first septal activation, then there is a activation of the left ventricle, then it goes to the impulses goes to the base. So whenever there is hypertrophy of this, uh, there will be increased R wave and it will be as good as S wave in V1. Okay, and similarly in V6, the R wave will be small in size as compared to S wave. So, as we have seen in normal ECG, we find and the amplitude of the R wave increases from V1 to V6 and the amplitude of S wave decreases from V1 to V6. And but in right ventricular hypertrophy, the R wave will be more in V1 and more or we can say equal to S wave in V1 and gradually its size decreases when it reaches to V6. So remember these criteria, the ratio of R wave to S wave in V1 more than 1 mm, more than equal to 1, or we can say QR uh, in V1, and third one, RS ratio of R oblique S wave in V5, V6 less than 1, or we can say deep S if we find deep S wave in V5, V6 more than 7 mm. It is suggestive of right ventricular hypertrophy. The sensitivity and specificity of these criteria is shown as the R by S in V1. It has a sensitivity of 98%, sorry, specificity of 98%, but the sensitivity is only 6%. Similarly, QR in V1, it has a 99% specificity. This R by oblique S wave in V5, V6, it has a specificity of 93. Similarly, deep S wave in V5, V6, it has a specificity of 90%. If we see the sensitivity, these are very less. So this is not a gold standard. To find out the exact cause of exact right ventricular hypertrophy, we have to do 2D echo. That is a gold standard to diagnose the right ventricular hypertrophy. ECG just gives you the idea that the patient is having right ventricular hypertrophy. Coming to the left ventricular hypertrophy, as we know, there is the position of the vector will be like this. So we will get a, uh, increase or tall or wave in V5, V6. So the criteria you should remember is only few that R oblique S wave. Sorry, I once again repeat. Due to the hypertrophy of the left ventricle, there will the vector strength will be more towards the this side. Since it has a more mass at left ventricular hypertrophy, we will get a tall or wave in V5 and V6. So the important criteria for left ventricular hypertrophy is the or the R wave in lead 1 plus S wave in lead 2. If it is more than 25, it is suggestive of left ventricular hypertrophy. It has a specificity of 100%, but if we don't use it commonly. Similarly, R wave in ABL lead. This is ABL lead, R wave in lead ABL. If it is more than 11, then it is also suggestive of left ventricular hypertrophy. The most common criteria which we people use is the S wave in V1 plus R wave in V5 or V6. If the sum is more than 30 mm, it is suggestive of left ventricular hypertrophy. It is called Sokolov-Leon Sokolov-Leon equation, or we can say Sokolov, or we can say Sokolov criteria. That is S wave in V1 plus R wave in V5 or V6 if the sum of these two is more than equal to 35 mm. It has a specificity of 100%. Some people also use this corner voltage criteria, that is R wave in ABL plus S wave in V3. If it is more than 28 mm, means more than 28 small scale in men and more than 20 scale in women, it is suggestive of the left ventricular hypertrophy. So these are the few criteria which we can remember to establish the left ventricular hypertrophy in an ECG. Recently, a new criteria has been introduced for diagnosis of left ventricular hypertrophy. This is called low pressure criteria. It is basically we have to see the deepest S wave in any of the precordial leads, that is chest leads, and S wave in V4. We have to find the deepest S wave in any lead, that is chest leads, and S wave in V4, and we have to combine them. That is the sum of deepest S wave in any lead plus S wave in V4. If it is more than 23 millimeter, means more than 23 millimeter or more than 23 small scale in female, and more than equal to 28 small scale in male, then it will suggest us left ventricular hypertrophy. That is deepest S wave in any precordial lead plus S wave in V4. The sum of these two, if it is more than equal to 23 small scale in female or more than 23 uh, more than 28 small scale in male, then it will be suggestive of left ventricular hypertrophy. These are the few criteria for diagnosis of left ventricular hypertrophy in presence of complete left bundle branch block. Left bundle branch block we will discuss in our next blogs. The criteria is R wave in lead ABL if it is more than equal to 11 mm. It has a specificity of 100%. Similarly, the electrical axis, if it is more than equal to 40, or S2, the S wave in lead 2 is more than equal to R wave in lead 1, it again has this specificity of 100%. Uh, if S wave in V1 plus R wave in V5 or V6, if it is more than equal to 40 mm, S wave in V2 more than 30 mm, and S wave in V3 if it is more than equal to 25 mm, it has a specificity of 90. These are the criteria for diagnosis of LVH in presence of complete left ventral branch block. Similarly, we have criteria for diagnosis of left ventricular hypertrophy in presence of left anterior fascicular block. But before diagnosing LVH, you should be able to diagnose left anterior fascicular block. This again I will discuss in my subsequent blogs. But in this, remember this, you can remember this, that sum of S wave in lead and maximal sum of R and S in any single precordial lead. If it is more than 30 mm, more than 30 mm, it is suggestive of LVH with left anterior fascicular block. That is, we have to see S wave in lead 3 plus the maximal sum of R and S in any single precordial lead. If their sum, if it is more than 30 mm, it is suggestive of left ventricular hypertrophy uh, in the presence of left anterior fascicular block. Biventricular enlargement, it is usually seen in the precordial leads. If both R and S waves are very huge and they are of almost equal size, then we can say that both ventricles are enlarged. This is called cat's rectal phenomena. If R and S waves are huge in precordial leads and they are almost equal, we call it as a biventricular enlargement. Now we will come to some ECGs and we'll find out what sort of hypertrophy is there. Here if we see that S wave are quite deep in V2 and R wave in V1 as compared to R wave in V1, and R wave are also enlarged in V5 and V6. It is suggestive of, if we take out their sum, if we use that Sokolow phenomena, that S wave in V1, R wave in V5 or V6, if we take their sum, that is equal to more than equal to 35 mm, is suggestive of LVH. And if we apply low pressure phenomena, that deep S wave in any precordial leaf plus S wave in V4, if their sum is more than 28 or more than 23 in female, it is suggestive of left ventricular hypertrophy. Okay, I hope you understand. And even this, if we see the T waves are like asymmetrical T waves suggestive of strain pattern, and that strain pattern is usually seen in pressure overload states. Again, the strain pattern is over here. If we see in this ECG, the R and S wave are almost equal and they are huge. It is suggestive of biventricular enlargement. Even the strain pattern is also seen over there. At if I tell you what is the axis in this ECG, this is AVF and this is lead one. It is left axis deviation. Left leaves. I hope you remember. Left leaves and right reaches. So biventricular enlargement with strain pattern with left axis deviation. I hope you understood the how to find the is ventricular hypertrophy, whether it is a left ventricular hypertrophy or right ventricular hypertrophy or biventricular hypertrophy in an ECG. ECG gives us the picture that these are the criteria which show the features of left ventricular hypertrophy or the right ventricular hypertrophy. But the gold standard for diagnosing the ventricular hypertrophy is 2D echo. So I hope I'm able to make you understand. Please read the standard textbooks for more updates and more